you to the Draft Trusted Exchange Framework Q&A session with Genevieve Morris. So for those on the phone, we did want to share that you can now also submit questions by raising your hand, and we will unmute you at this time. You can also continue to submit your text questions and comments through the questions panel. We'll also be moderating that as well. And also, please note that this webinar is being recorded, so if you do not want to be recorded, please drop off now. And it will be posted to healthit.gov on the Trusted Exchange Framework webpage as soon as we can. Okay, so with that, I'm going to hand it over to Genevieve. Genevieve, you can hear us, correct?
I can hear you, yes. And just one note, I actually don't think the hand raising feature is available. So, because I don't see it in my own, so I'm guessing others don't either. So if that is not available, just please submit your questions via chat. I want to just apologize for our technical issues and the late start date. We will run until 4:45 to make sure we give a full hour to folks for questions, unless, of course, we don't have enough questions to fill that time. For just a couple of other housekeeping type items while folks are still joining the line, there are a couple of slides that we'll present, but this really isn't the full deck. If you're interested in seeing the more detailed slides, all of this content is pulled from the User's Guide to Understanding the Draft Trusted Exchange Framework, which is up on our website. So I highly recommend that as you read through the Draft Trusted Exchange Framework document, that you take a look at that User's Guide, which incorporates a lot of this content in to help you understand the framework as you're reading through it. So just a couple of notes that, or a couple of slides that are somewhat based off of questions we've gotten so far. And then we'll jump into a couple of questions from the previous webinar, as well as let you all ask some new questions or additional questions. As we've been presenting the Trusted Exchange Framework to folks, one of the questions that's come up pretty frequently is what exactly is a Qualified Health Information Network or a Qualified HIN, because this is a bit of a new concept for folks. And so I wanted to go over in a little bit detail what a Qualified HIN is, as well as the types of qualified HINs that we think could exist. And I did just see the hand raising feature is back. So when we get to that question time, if you want to use that method, that works as well. Anyway, so a qualified HIN is first of all, a health information network. So you have to meet the definition of health information network, which is in both the framework as well as the user guide. And then you have to have a couple of other capabilities on top of that. And so it is, at the end of the day, a network of organizations who are working together. A qualified HIN has something called a connectivity broker service, which basically allows for broadcast query across the network. And so that means they have services like a record locator service and a master patient index, so that we can scale and actually be able to support a broadcast query. Now, for those of you who are maybe not steeped in some of this terminology, a broadcast query means that I'm looking for all the information on Genevieve Morris, no matter where that information may reside. That is different than a directed query, where I might know that Genevieve went to Dr. Smith, or I might know that Genevieve went to MedStar Health System, and I just want to query those individuals to get particular pieces of data about Genevieve. That's sort of the difference between the two. And for scalability, to make this nationwide, we felt that it was important to include the connectivity broker requirements as part of a qualified HIN. And then a qualified HIN is made up of participants and end users. And so sometimes those are going to be the same. So a health system might be both a participant and an end user, or they may just be an end user. It's going to depend a little bit on the makeup of the network. If you have the next slide, a couple of examples of what a qualified HIN could look like. And these are just examples that we've put out there, so feel free to ask us questions on this when we get to that period of time. Example one could be a qualified HIN that's made up of all payers. So if a couple of the national payers, as well as some of the Blue Cross Blue Shield payers, wanted to go in together and create a qualified HIN so that they could more easily get clinical data from providers and more easily share administrative data back with providers, that could be one amalgamation. And in this case, the end user and the participant would probably be the same. The payer would likely be the same organization serving in both of those roles. If you go to the next slide, a second example is a qualified HIN that is vendor focused. And so they have EHR vendors, they have health IT modules, they have analytics products, they have care coordination vendors and folks like that making up part of their participant structure. Even maybe an HIE vendor could be in that space as well, in which case the end users are going to be the end users of those platforms. So it could be a physician who's using the EHR system. It could be a care manager who's using a care coordination platform. It could also be a patient who's using a personal health record vendor to access their information. If you go to the next slide, example 3 could be a qualified HIN that has federal agencies and health systems and HIEs all mixed in together, in which case the end user might also be a physician, or it could be the federal agency itself, or it could be users of that federal agency's health IT systems. There's all kinds of different ways that could work out. And if you go to, I think we have one more example in there. Next slide. Excellent. Example 4 is a number of regional HIEs all joining together to form their own qualified HIN. So part of what we want to make sure we explain is that the way we set up the definition of a qualified HIN, a single regional HIE would likely not meet the requirements to be a qualified HIN, but a group of HIEs together, or an HIE that has regionalized their services, could meet that definition. Likewise, a single EHR vendor network likely would not meet the definition of a qualified HIN. But if that EHR vendor joins a network that has other vendors in it, or a network that has other HIEs in it, then that network could be a qualified HIN. And so part of the intention behind some of that is ending up with a small number of qualified HINs. So as we think about supporting broadcast querying nationwide, which we think is important to do for patient care, without centralized infrastructure, or not having centralized infrastructure, you really end up needing a small number of organizations who can all query each other when a query comes through, because really we're talking querying on the order of magnitude of millions or billions a day. And so to organize this without centralized infrastructure, we've set up the qualified HIN approach to end up with a smaller number of qualified HINs. And so at the end of the day, we're really talking about a network of networks of networks. And so that's just the way that we've envisioned this. And we're certainly open to questions on it, as well as comments from you all during the comment period. If you go to the next slide, I think there's just one more slide, and then we'll get to some specific questions. This is just the overarching, how will the framework work? So we as ONC are intending to work with a recognized coordinating entity, who would be an industry-based organization. We're going to put out a cooperative agreement to choose that organization, which means it will be an open and competitive bid process. And then we will work collaboratively with that RCE to build out the full common agreement, which would be sort of the managing document that the qualified HINs would agree to or sign on to, in quote marks. And then what will happen is when an end user, so let's just say it's Dr. Smith, and they want to get all the information on me, Dr. Smith would send a query up potentially through their EHR vendor, who would then send it to the qualified HIN, who would broadcast that out to all the other qualified HINs on the network. They would respond back and say, yes, we have information on Genevieve Morris. No, we don't have information on Genevieve Morris. For the folks who do, they would then, the end user's qualified HIN would then ask them for that data and would consolidate that data and send it back through the participant to the end user. Likewise, let's say it's an individual patient, and let's say I want to go on and use my personal health record vendor to get my data. I would sign into my PHR. My PHR, who's a member of the qualified HIN, would send that request to the qualified HIN. The same broadcast query would go out and bring all of my data back into my personal health record. That's the way we're envisioning this to occur. And so we wanted to give a little bit of information around that to answer some of the questions we know that we've gotten around it. I think if you go to the next slide, we're pretty much on to question time, I believe. Excellent. So I think we have a couple of starter questions that Rachel or Mitch will be asking, and then certainly as questions come in, either raise your hand if you want to ask a question over the phone, or you're welcome to ask your question via the chat feature.
Great. Yeah, thanks, Genevieve. So just a reminder, folks, if you do want to ask a question verbally, we ask that you use the raise the hand feature in your dashboard. And you will also need to make sure that you enter your PIN number, otherwise we can't unmute you. So please do that as well. So Genevieve, we're going to start with the first question. What factors do you anticipate will determine who becomes a QHIN?
Yeah, so it's a couple of eligibility requirements that we've built in. So one is that they have the capability of receiving and sending out broadcast queries. So that's where the connectivity broker services come in. In addition to be able to send and receive those broadcast queries, they sort of act as a gateway to all of their participants and end users. And so organizations that have the ability to really take that query in and get all the data back and send it back in a coherent fashion to another qualified HIN is one of the requirements. In addition, we have a requirement that the qualified HIN be participant neutral, which means a couple of things. One, it means that to be participant neutral, you are not one half of the exchange. So this is why EHR vendor networks likely would not qualify on their own as a qualified HIN, because they're always one half of the exchange taking place. And really that's an effort to introduce some competition into the market that might not be there right now, and really create a level playing field for folks who maybe aren't the big guys, who perhaps don't have the funding to do some of this. And so that's a couple of the things that we're looking for as part of being a qualified HIN. We really want to see folks kind of band together and create these larger networks so that we have scalability to support, you know, millions upon billions of queries each day.
Thanks, Genevieve. So we're going to go to the phone. I have Carrie. She's on the line. So Carrie, I'm unmuting you. Do you want to ask your question?
And
sure,
if you can make sure you say
your
your name and organization, that would be really helpful.
Yeah, Carrie Gaudio. I'm with the Florida HIE. I have a couple of questions, but I'll start with, so there are 3 functions listed as a requirement for a connectivity broker. So those would then in turn be requirements for any QHIN to be considered a QHIN. And has it been determined how many existing HIEs would fall under that umbrella? So that's one question. Should I go to my other ones, or you want to respond to that first?
So I'll respond to that one first. So as I noted, a single regional HIE would likely not meet that definition with not because they don't have the connectivity broker piece, because a number of them do, but they wouldn't meet the participant neutral requirements. That being said, there are a number of networks that are both national and getting closer to national, as well as regional, that could meet the connectivity broker requirements and the participant neutral requirements. If you just kind of look at the folks who are out there right now, we think there's a number of folks who would qualify.
Okay, and then kind of in line with that, you speak about, you know, the requirement to have broadcast query capacity. Has it been determined, like, the size of that capacity? You know, there are certainly size limits in varying HIEs, and so I'm just curious if there will be specific capacity requirements.
We haven't put any particular capacity requirements into the framework. I think we would be looking for some public comment around whether we need to put some minimum requirements in. I think part of what folks definitely need to consider about being a qualified HIN is that they have the infrastructure in place to be able to handle the scale of the full nation. And I think I mentioned this in the HITAC committee yesterday. You know, in reality today, because most of the data that's being exchanged is from health systems, we're only exchanging about a quarter of the data that's actually out there, because most care happens in the ambulatory space. I think right. I did a little research, and in 2014, there were 880 million visits to ambulatory doctors, and there was, you know, less than half of that to ED visits in the same year, right? So I think we need to make sure that we're planning for that capacity. And so as folks think about being a qualified HIN, you know, they really need to think about having the infrastructure in place that will enable them to handle the number of queries that we would expect.
Right, because I mean, that's pretty massive.
Correct.
And so,
yes. On the upside, computing power has actually come a long way in the last 5 years. And so, I mean, that's how blockchain exists, right? Blockchain couldn't have existed 5 years ago with computing power we had. So we think that it is very doable, but folks really do need to think about that as they think about the requirements.
And as part of those requirements to be a QHIN, the consolidation of CCDs would be required at the individual QHIN level before responding to queries from other QHINs, correct?
Yeah, so it's a great question, and I do want to clarify, there are two ways that you can consolidate CCDAs. There's consolidating all of the data together into one CCDA, which is one option, and then there's consolidating all of the CCDAs into one message. So you might still get multiple CCDAs, but they come across in one message. We would allow for either of those under the current way that we've written the Trust Exchange Framework in Part B, because I think there's good reason to have both of those options available. Yeah. All right, next question. Do we have someone else on the phone, or do we want to take one of the, maybe Rachel, let's go in between a written question and a phone question, maybe alternate.
Okay, sure, no problem. So we're going to take another written question. So this question is, so how does the TEFCA address the need for source health data record provenance, who, what, when, where, why, to be conveyed, exchanged to each ultimate point of access or use?
Yeah, it's a good question. So in conjunction with releasing the framework, we also released something called the U.S. Core Data for Interoperability Glide Path. And we built in a requirement to the Part B terms and conditions that the qualified HINs and downstream folks, their participants and end users, would have to be able to exchange the data in the U.S. Core Data for Interoperability version 1, which is in the glide path itself. That version 1 includes provenance data. And for those of you who are not familiar with the term provenance, that's really the metadata, so data about the data, which tells you the who, what, when, where of who created the data. So that would be a requirement for folks to support out of the gates, which would help alleviate that need that we have right now to know where the data originates from and who created it. Next question.
Great, thanks, Genevieve. So we're going to move to the phones, and we're going to take a question from Brian. Brian, I'm going to unmute you, but I ask that you just keep your question as short as possible, since we do have a long list of other folks as well. And say your name and organization. That would be great.
Yeah, this is Brian A. Hare. I work for Aetna in our Medicity business, and I guess it's a sort of a two-part question. Would claims data be considered EHI for purposes of the TEFCA? And assuming that it would, then would organizations like clearinghouses potentially at least meet the definition of an HIN?
Yeah, it's an excellent question. So the definition of electronic health information, which is a new definition in the space, and so I highly recommend folks check it out, it does include administrative data. What it does not include is the HIPAA transaction set. So I think we actually have some footnotes in the document that specify that we're not talking about exchanging the HIPAA transaction set that's required by CMS over the network. But we also recognize that there is a need, particularly by healthcare systems and providers who are in value-based payment models, to have access to the administrative data so that they can combine it with clinical data and better manage their patient populations. Vice versa, payers need clinical data to be able to do the same thing. And so we do envision that administrative data would be on the table. It's partially why we renamed the Common Clinical Data Set to the U.S. Core Data for Interoperability. That being said, clearinghouses certainly could consider being part of these networks. They would, like everyone else, have to meet the qualifications of being a qualified health information network if they wanted to serve in that role. Or they could join a qualified health information network and provide some of the administrative data that they have. So that is certainly an option.
Thank you.
Great, thank you. Thanks, Brian. Appreciate your comments and question. So moving again to the questions that are coming in online. So Genevieve, how does ONC envision consumer apps, connecting into the infrastructure created by the TEFCA in order to exercise individual access if the app is not an end user or participant? Or does ONC expect that consumer-facing apps will be used either participants or end users?
Yeah, so it's a great question. And I think this could go a couple different ways. So in the Trust Exchange Framework itself, when we talk about individual access, we actually use a pretty broad definition that is an updated OCR definition that sort of clarifies that a third party acting on behalf of an individual at their request is the same as the individual themselves. And so app developers could either be a participant in one of the qualified HINs, and the end user is making the request. They could also themselves be an end user who's making the request on behalf of individuals. We set up the language to really allow for either one of those to occur, and we tried to be as broad as possible to allow consumers the largest amount of flexibility to be able to get their data.
Great, thank you so much, Genevieve. So we're moving to the phones again, and we have a question from Summer. Summer, I've unmuted your phone. If you could just say who you are and where you're from and ask your question, be short and sweet. Thank you.
Hi, this is Summer Ort from Michigan Health Information Network. Do you know when the RFP for the recognized coordinating entity might be released and when that RCE selection might occur?
Yes, a great question. We are aiming to release the funding opportunity announcement because it's a cooperative agreement. It won't be an RFP, it's a SOA in our legal or government terms. We're looking to release that hopefully around the April to May timeframe in that general area. And then our goal is that we would actually have the RCE in place no later than August so that we can work with them to build out the common agreement and meet some of the other timelines that we've set out towards the end of the year.
Great, thank you.
Mm-hmm.
Thank you, Summer. Okay, so we're moving back to the online questions. Since participation in the program will be voluntary, yet HINs will incur costs to build out marginal capabilities, not to mention other factors that have led to resistance. What will be the incentive for HINs to participate and become qualified HINs?
Yeah, so what we hope will happen is that folks will understand that this is a market opportunity and that this is really where the market is shifting to. I think we've talked a little bit about this. You know, we feel like it's important for the market to shift away from hoarding data to really sharing that data and building other services. And so what we hope folks will see is an opportunity to start moving in that direction towards a more innovative and fair marketplace that allows them to build really innovative services. And so becoming a HIN or voluntarily signing on to the common agreement will get them access to the data that has been thus far quite difficult to get access to and allow them to provide some really innovative services around analytics and risk management and care coordination. So we're hopeful that folks will understand the market opportunity that's out there.
Great, thanks so much. So we don't have any other verbal questions, so we're just going to continue to ask the questions that are coming in via chat. Can you clarify the intent of patients interacting directly with a QHIN? Or is the intent that they interact through their provider, PHR, app vendor, et cetera? In that context, can you clarify intent of the QHIN managing and documenting patient consent?
So there's a couple questions I think baked in there, so I'll start and then hopefully get to all of them. We don't want to presuppose the type of participants that any qualified HIN would have, because there's a lot of different ways that you could set this up. And so I could see there being a qualified HIN who wants to have all participants be individuals and, set up, some sort of product for them to do that. So that is certainly a possibility. The other possibility is that I could see personal health record vendors and app developers that are consumer facing joining qualified HINs and being that conduit for the patients to be able to get access to their data. So I think there's a couple of different ways that could play out, and we're very open to seeing how folks decide to do that so that consumers can have easier access to their data, because at the end of the day, that's what a lot of this is about. The second question, I think, was around consent and recording it or managing it. I think we don't necessarily have requirements around managing consent for the qualified HINs. What is in Part B is a requirement that if a patient has expressed a consent preference, that the qualified HIN needs to respect that preference and promulgate it across the system. What we are very closely monitoring are a couple of industry efforts around electronically communicating that consent in a standardized, easier fashion. And we are very much hoping that the timelines will align for us to build some of that into the final trust exchange framework so that we can better communicate the consent preferences of individuals.
Great, thanks so much, Emily. So we have another verbal question. Richard, I'm going to unmute you if you could say who you're with. And let's see, maybe not. Hold on. Yeah, I think, Richard, you're self-muted, so I don't know if you can unmute yourself.
Yeah. Keep paying attention now.
Richard? Oh, okay, well, we'll come back to you. No problem. Save your question. All right, so we're going to move on to another online question. Will broadcast queries be real-time or asynchronous? It seems the QHINs would be at the mercy of the speed and capacity of the source system. Given the large number of systems and number of queries, real-time performance would seem to not be viable.
Yeah, so it's a very good question. So two parts of an answer I would give. There are two concepts in the framework. There's the query for an individual patient's data, and there's the query for multiple patients at once. Because of the bandwidth issues, we have actually in Part B in Section 8 specified that broadcast queries or even directed queries for population level data can and probably should be asynchronous so that we're not taking down a whole system bandwidth-wise. So that is a really important clarification that folks will not be competing with population level data queries when they're trying to treat the patient. The other point that I would make is part of the way in which we set up the connectivity broker options is to try and manage that bandwidth issue when you're doing broadcast queries for a single patient. And so I would say, as I think I stated earlier, that folks who come in to be the qualified HIN need to have in place the infrastructure to be able to support the bandwidth necessary for the broadcast queries for individual patient data. But those are some important distinctions that I think folks need to make sure they understand that, we are very concerned about the scalability part of it. And so, if there are other things we need to build into the framework to ensure that we're getting to scalability, then we need to do that. This sort of other piece that I would throw in there is that we don't anticipate that every query will be a broadcast query. So there are many times where you know exactly the information you want. So for example, if you have a diabetic patient whose care you're managing and you know that they just went to the hospital ED because they had some sort of event, you're likely not going to broadcast query in that case, right? You know the hospital they went to because the patients typically remember at least the hospital they went to, or you received an alert of some sort that the patient was at the hospital. You're going to do directed queries for those kinds of things. So I expect that at the end of the day, we will end up with a combination of direct queries and broadcast queries, which will allow the system to be able to manage the bandwidth.
Great. So it looks like we are going to try to go back to the phones. We have a question from Adrian. Adrian, I've just unmuted you, so if you could say who you are and where you're from and just keep your questions short and simple, that'd be great. Thank you. Adrian? Oh,
I think I heard him.
Okay, can you hear me now?
Yes, perfect.
Okay, so this is Adrian Gropper from Patient Privacy Rights. How do people opt in or opt out of having a particular encounter tracked, particularly if payers and pharmacies, et cetera, are participating?
Yeah, so in Part B, what we tried to build in is the ability for them to opt out at the level of their provider or physician. So they may not be opting out directly with the qualified HIN, depending on sort of the relationship between them and the qualified HIN. But we did build in requirements that if they're with their provider and they want to opt out of having their data exchanged, that they communicate that to their provider, and it is the responsibility of that end user to communicate that up to the qualified HIN, and then for the qualified HIN to respect that request and perpetuate it across for future data exchange. So that is built into Part B. Like I said, the manner in which that consent gets communicated, we are very hopeful that some of the work coming down the pike right now is actually going to allow us to build that into the final to make it easier for patients to communicate that.
So in other words, the insurance companies would have to manage consent on a encounter by encounter basis in order to do that.
I'm not quite sure that I understand the question there. I'm sorry.
Well, patients generally have a choice of provider, but they do not have a choice of infrastructure like clearinghouses or insurance company or pharmacy in some cases.
So what I would say is that everything we've put into the framework indicates that you have to follow applicable state and federal laws. So I think my answer would be that they would have to manage the consent just like they do now in accordance with HIPAA and any other state laws that might be stricter than HIPAA.
Great, thanks Adrian for your questions. So moving back to the chat, we have some more questions. So can you define what you mean when you say participant neutral, and why an HIE would not be participant neutral if they have a variety of participants such as payers, providers, hospitals, etc.?
Yeah, so participant neutral means a couple different things, including participant neutral of like organizations. And so when we think about regional HIEs, while they have participants from many different types of groups underneath of them, they themselves are one organization. So they are therefore not participant neutral. Multiple HIEs together becomes participant neutral because they have multiple HIEs sharing data. I would recommend that folks take a look back at the definition in the framework as well as in the user's guide to get a better understanding of what we mean by that. But that's sort of what we're aiming for. And part of, as I said before, part of the participant neutral requirement is to bring more competition into the market. And by bring competition, I mean set a level playing field, as well as ultimately get us to a smaller number of qualified HINs.
Great, thank you. So we're going to continue to move through some of the questions in the chat. Next question is a QHIN allowed to store data that flows through its network and then use the data for non-TEFCA purposes?
So there is a clause in Part B that indicates that once the data has been exchanged for the permitted purposes, for one of the allowed permitted purposes, that qualified HINs or their end users are allowed to aggregate that data and use it for their permitted purposes. One of the things we saw as we looked at the various agreements out there today is that a number of the networks actually prohibit aggregation of the data that you've exchanged, which I understand why they did that. However, it doesn't allow for things like providers wanting to work with a third party like a QCDR or they're like a third party analytics vendor who must aggregate data to run quality measures and maybe wants to use a network to be able to exchange that data rather than having to build a new interface to everyone they want to work with. And so there is a clause in Part B. I apologize that I don't remember exactly what section it's in, but I would highly recommend that you check that out. I think it might be Section 4 or 5, but take a look at that for more information.
Great, thanks, Genevieve. So our next question is around information blocking, and I know that we have Elise Anthony, who is our Office of Policy Director here at ONC, so she may want to chime in as well. So would it be fair to say that the TEFCA US CDI represents a clear line regarding information blocking, such that participating in the framework is proof that you are not info blocking?
I'm going to punt that over to Elise.
Hi, everyone. Thanks so much for the question. The TEFCA itself is a voluntary document, and Congress has laid it out as such. Information blocking is a completely different conversation. And I noted yesterday during the HITECH or the Health Information Technology Advisory Committee meeting that we are in the process of looking at some of the reasonable and necessary exceptions that might exist around information blocking, and we're putting together a rule on that. Once that rule does come out with the agency's thinking on how we are thinking about information blocking, we would love to hear any comments that folks have on whether we've hit the right notes or there's anything we've left out. But just to be clear, that is in fact a separate conversation from the Trust Exchange Framework, and that the Trust Exchange Framework and the resulting common agreement are voluntary instruments that are separate from the provisions related to information blocking.
Great, thank you, Elise. Anything else, Genevieve, you want to add?
Nope, that was nothing to add there.
Sorry, just checking. Okay, so next question. Will the definition of healthcare operations be expanded to allow for additional quality assessment and improvements such as outcomes, evaluation, care coordination, and population health management among participants?
So I'm a little confused on the question because healthcare operations does already include those items in that definition. So by including that as a permitted purpose, what we've actually attempted to do is set up an environment where providers who want to work with a third-party vendor other than their EHR vendor to do things like care coordination and population health management could use one of these health information networks as a way of exchanging data with them rather than having to build a one-off interface. That's also actually why we included the population level data exchange, because certainly if you're a provider and you want to work with a third-party vendor or an HIE or a QCDR to do your population health management, it's going to work a lot better if you can share multiple patient records at one time. And so we've built that in as a permitted purpose specifically to allow for that type of relationship and that kind of use of the health information network. So it'd be helpful to understand from the questioner if they feel like the current definition of operations somehow doesn't include that for some reason. My understanding is that it does.
Great. And since we're talking about permitted purposes, why is the ONC expanding permitted purposes beyond the HIPAA requires, what HIPAA requires?
Well, so to be clear, we're not really expanding beyond what HIPAA requires. We are expanding beyond what networks right now often include. So when we did our review of all of the participation agreements that are out there right now and the trust frameworks that are out there, the majority limit to treatment purposes only. Some of them might have a couple other permitted purposes in there, but it's very limited. And at the end of the day, what we want to do is create this concept of a single on-ramp, which is a figurative single on-ramp, not necessarily a literal one as far as when you think about onboarding to something. But we want providers to be able to pick one network. And instead of having to continue to build point-to-point interfaces, whether it be with another provider that they want to share data with, or with another vendor or organization that they want to work with for their own purposes, we want them to be able to use the health information network to do that rather than having to build an individualized custom interface. In order to make that a reality for providers, you really have to expand your permitted purposes beyond treatment. Because if a network only allows for treatment, that means I can't use that network to get the data over to my third-party vendor or QCDR. And we really think that that's important to enabling lower costs around all of this, which right now is quite costly to providers, and really opening up the market for innovative products to be able to come in and work more easily with providers. At the end of the day, there's some really cool products out there that honestly just don't perform well because they can't get access to the data. And we want providers to be able to use those networks to give them, honestly, more choice in the market around who they work with.
Great, thanks, Genevieve. And I just want to remind people that because of the technical issues we had in the beginning, we're going to be going to 4:45 today, so there is still about approximately 15 minutes left. Moving on to the phone, Richard, I think you are you able to hear us? And please introduce yourself and ask your question.
Yes. Okay. Can you hear me? It's Richard. Hi, my name is Richard.
Yep, we can hear you.
Uh-oh, there might be two Richards.
No, it's okay. I think we can hear you. Go ahead.
Okay, great. I remember last time you talked about the business model for if you form a QHIN, because I know when I've spoken to some of the HIEs in the past, by the way, it's Richard Singerman from ESAC, they've talked about that with the different electronic health record vendors, as the population grows in the system, it started to really become prohibitive for the HIEs to pay for the exchange costs for the electronic health records. But I remember last time you guys talked about quote unquote like a reasonable charge. So obviously there's the business model once the data is in place and you can put apps on top of the QHIN, but can you talk about the business model a little bit more of the QHINs themselves?
Yeah, so it's a great question. So a couple things on the fee structure first, and then I'll get into the business model. So in the Part B, and I again apologize, I don't know the section number off the top of my head, we have said that between qualified HINs, you're not required to charge fees, but if you do charge fees to another qualified HIN, they do have to be reasonable. What we've tried to do is allow qualified HINs to recoup the cost of the infrastructure that they're setting up and maintaining, while also being able to innovate and continue to maintain that infrastructure. We did not set any of the fee requirements or structures around what a qualified HIN would charge its participants. We did, however, say that they have to report that data to ONC so that we can monitor for things like price gouging. From a business model perspective, what we've tried to set up is a paradigm where a very broad set of use cases get covered via query, but we left a number of things off the table for qualified HINs to be able to create services that would be able to sustain them and create a business model for them. So for example, you'll notice we didn't include some of the push use cases in what we set as the minimum, so that qualified HINs could perhaps have a business line around notification services, which are quite popular right now, and be able to charge their users for those services and thereby create a sustainability model. What I think will happen is as the data itself opens up, I think we're going to start to see really innovative ideas around what you can do with that data while still following the law and still following patient consent preferences. What you can do with that data to provide services, not only to physicians and health systems, but also to individuals and consumers that could be really valuable and be service lines. And so we think that that's how the market will start to evolve and develop. Certainly only time will tell, but that's what we tried to set up.
Thanks.
Thanks so much, Richard. So we're moving again back to some of the chat questions. Is there a limit to the number of QHINs, and will all entities that apply and meet the criteria be qualified, or will there be some sort of competitive process to limit the number of QHIN nodes?
So we're not setting a top-out number. I think what we said is we think for scalability and broadcast query, it needs to be small. Again, very open to comment on whether that's true without centralized infrastructure. So we're not setting a number. What I would say is anyone who, to be a qualified HIN, it won't be so much an application process. It will be someone going to the RCE and saying, I am willing to sign on to the common agreement. I do meet the criteria to be able to sign on to it. Here you go. Here's how I've met the criteria. So in that sense, there won't be a process where you have to apply and you might get turned away. So long as you meet the criteria and you are willing to sign on to the common agreement and abide by it, you will be welcomed as a qualified HIN.
Great, thanks, Genevieve. So this is a question specific to the US CDI. So are you all looking to expand the number of data elements that can be retrieved?
Yes, yes, we are. So part of the U.S. Core Data for Interoperability glide path that we released for comment is a plan over time to take data elements from emerging status to candidate status to being part of the US CDI version. And so we are trying to actually build out a roadmap for how that occurs. We are very much looking for comment from folks on that glide path on, one, whether we've got the right data in the candidate status, but two, like whether we've actually set up a correct process to be able to prioritize it and add to data over time. It is obviously important, not only for the industry, but to meet our CURES requirement of all data, that we get to more data over time, whether it's structured or unstructured. And so we are hopeful that setting out that roadmap on the US CDI will get us more data over time.
Great, thanks so much. So can you clarify, and you may have already touched upon this, but how the population level query would work and how do you ensure it won't cause bandwidth issues?
Yeah, it's a great question. So when we talk about the population level query, what we're really talking about is I have a panel of patients. So I'm either a physician with a patient panel, I'm a payer with a set of members, I'm maybe an individual who has a set of family members who I'm authorized to access data on, and I'm querying to get the data on that specific set of patients. What we did in Section 8 of Part B was build in an option to say that you are not required to do those population level queries in real time, and that in fact you should do them asynchronously so that you are not hitting bandwidth. We think by setting up that requirement in that way, we are dealing with the bandwidth issues, but again, open to comment from folks on that, but we've tried our best to set about provisions that will prevent those types of population level queries from bringing down the system.
Great. So just moving on through some of the questions in the chat. Given the interoperability measures included with MU and MIPS, has CMS contributed to the development of the trusted framework to ensure the roadmap is going in the right direction?
Yeah, so we worked with a number of our federal partners, both within HHS as well as external to HHS, in developing out the framework. So we certainly worked with CMS on it, and there's actually a couple different parties across CMS we worked with to make sure it met their needs. We worked closely with the VA, the Social Security Administration, DOD, and then a number of other HHS agencies who might need to use the framework, including the Indian Health Services, the Agency for Children and Families, the Agency for Community Services, and a number of others. We met extensively with them while we were drafting. They actually were given opportunity to review and provide us feedback prior to public release. And so far, we're feeling pretty good that we're helping to meet their needs. And then certainly in an ongoing fashion, as we review public comment and we figure out how we want to update it, we'll go through those same processes again to make sure that we're meeting with them and meeting their needs.
Thanks, Genevieve. So we're moving to the phones again. It looks like we have another Richard who has a question. So Richard Gibson, I've now unmuted you.
Hi, yeah, this is Richard Gibson at the Health Record Banking Alliance. And under the definition of individual access, it's the term designated record sets is mentioned, is used, but it's not capitalized. And so one question I have is, should designated record set be capitalized since it has a specific term of use referencing the specific HIPAA definition of that phrase? And then does its inclusion under individual access and TEFCA require that these record sets need to be sent by a participant or end users if requested by an individual? And does TEFCA believe that CCDA standard can be a container for this large data transfer to individuals?
All right, couple of questions there. So I think we actually purposely probably use the lowercase designated record set, though I'll have to check with the lawyers around that piece. For the individual access, really at the end of the day, it's EPHI, but then it's also the broader EHI definition, so electronic health information definition. What I will say, and what I would maybe caution folks on, is that while we want to give individuals as much access to their data as possible, the data that we are requiring qualified HINs to be able to support is the US core data for interoperability. So to the extent that some of a patient's designated record set data falls outside of that US CDI, we would not be expecting a qualified HIN or an end user or participant to be able to support that over the network. And that's primarily just not because it's not important to get them access to that designated record set, but because there's only so much system can do, and there's only so much we can do standards-wise. And so over time with the US CDI, we are going to get to that fuller designated record set. It's just going to take us a little bit of time, and so out of the gate, likely they won't be able to get access to everything that's in that required set. But I'll double check with our lawyers around whether that should be capitalized or not, and so we'll revisit that with them as well as with OCR.
Great, thanks Genevieve, and thanks Richard. So we're going to take one more from the chat. So how would a provider that is not a member of an HIE participate in this network?
It's a great question. So I think there's probably a couple ways that you could anticipate participating. So one, if your EHR vendor or other health IT vendor that you use joins one of the qualified HINs or joins a network that's part of a qualified HIN, then you would automatically, you might have to turn some stuff on, of course, but you would get access to the data across the qualified HIN. That's very similar to some of the arrangements we see now with some of the national networks. The other option is that you yourself could find a qualified HIN and join it on your own, or find a vendor who is a member of a qualified HIN or an HIE who's a member of a qualified HIN and join one of those. I think there's a couple of different options of how that will work out, and it's going to depend a little bit on what your preferences are as a provider. But we're hoping that you'll have some choices in that mix so that you could either go through your EHR vendor or you could go separately through another organization.
Great. So now we're moving back to the phones. We're going to take a question from Dan. Dan, I've unmuted you. Do you want to ask your question and say where you're from?
Yes, thank you. My name is Dan Paoletti. I'm with the Ohio Health Information Partnership. And my question is around the minimum necessary HIPAA rule. If you have a QHIN that is made up of health plans, as one of your examples, that's broadcasting queries, how will the covered entities that are part of another QHIN or another HIN know what to respond back to comply with that minimum necessary rule?
Yeah, so it's a good question. We do, within Part B, clearly specify that you have to follow all applicable laws when you're doing your querying, and so that means following the minimum necessary rule. I think at the end of the day, that's going to work very similarly to how that works now. Where when someone sends a query and they specify the purpose for which it's for, you make the determination on which data is the minimum necessary. I will say what we don't want to have occur, and I think what sometimes occurs today is folks for competitive purposes use that minimum necessary requirement to avoid sharing data with folks that they feel may be their competitors or folks that they're concerned might use the data against them to gain competitive advantage. And so we don't want to see that occur, but we certainly want folks to follow the HIPAA rules. And so we would envision that that would continue to occur the same way that it does today when someone receives a query.
Thank you.
Great, thank you, Dan, and thank you, Genevieve. So moving on, can a participant of a QHIN refuse to share information with specific participants of a QHIN?
The answer to that is no. They cannot, particularly if it's for competitive reasons. So the only time that you can refuse to share the information with another participant is if it is prohibited by law. So let's say that it's a 42 CFR Part C, or I'm probably getting the number wrong, the 42 CFR stuff, where it requires consent, and you don't have consent on file. In that case, you could refuse to share the data with another participant, right? So you have to follow applicable law. Or if a patient has revoked its consent, or said you can't share my data, then certainly you can refuse. In all other cases, you need to share the data with another participant when it is requested for one of the 6 permitted purposes that we have listed in the TEFCA.
Great, thanks, Genevieve. And I think we have time for one more. Is the role of the REC to also ensure that the rules of the road are adhered to? What kind of auditing and oversight is anticipated for the TEFCA?
Yeah, so I think a couple of things to clarify within that is just around the structure of what we've put out. So What we've released is the draft trust exchange framework, which is both Part A and Part B. Part A being the principles and Part B being the minimum required terms and conditions. Once we get public comment back, we will update the trust exchange framework, which will continue to be both Part A and Part B, those principles and those minimum required terms. We will work with the RCE to draft the common agreement, which would include our minimum required terms and conditions. It would include all the other terms and conditions that you need to facilitate exchange, and it would have to align to the principles in Part A. So in other words, you couldn't add something to the common agreement that contradicts the principles in Part A of the trust exchange framework. We will then publish both the trust exchange framework, which is Part A and Part B, and the full common agreement in the Federal Register and on our website once all of that is complete. And over time, ONC will maintain the trust exchange framework, and we will work with the RCE to maintain and update the common agreement. We would anticipate that part of the RCE's role would be to ensure that qualified HINs and their participants via the qualified HINs are following the trusted exchange framework and following the common agreement. And so we would expect them to have some oversight capabilities. That means that as we're thinking about an organization from the industry who might think about applying for this, that we're looking for someone who has some experience with doing that, with a group of stakeholders and participants and making sure that they are following the rules. Because at the end of the day, it's going to be their job to deal with folks who are not following the rules through some fair and open and transparent processes. And then certainly they would need to inform us if someone was going to be removed from the network so that we could appropriately update the website listing that we are required by CURIS to keep. So we do anticipate that they would have some of those requirements in there. I would say historically, in talking to a number of the large networks that are out there, I think I've only ever heard of one time have they had to actually remove someone from a network who wasn't following the rules. And so it isn't something that happens that frequently, but when it does, we would expect the RCE to be on top of that.
Great, thank you so much. So I think we've reached our 4:45 deadline. We really appreciate everyone's participation. I'm sorry we didn't get to everyone's questions, but they will be taken into account into our public comments moving forward. Genevieve, thank you so much for taking the time to answer these questions from the audience. And thank you all very much. And so we are going to end the call.
Thank you.